Hello, good afternoon, everyone. First of all, I'm grateful for the organizer giving me this opportunity to present our clinical trial, both the mechanism of action and the clinical trial design. So the CD24Fc is a non-antiviral immunomodulator for COVID-19 treatment. This is my disclosure slide. First, I would like to have a brief introduction of our company, OncoImmune. The company is founded in 2000 and relocated to Rockville, Maryland in 2013. We developed first-in-class biologics for immunotherapy of inflammation and cancer. The first product, CD24Fc, is developed in-house. We have completed a phase 1 in healthy subjects. We also completed 2 phase 2 clinical trials for GvHD prevention. FDA already approved for our phase 3 clinical trial in GvHD prevention. Today, I'm mostly going to talk about this FDA-approved phase 3 clinical trial for CD24Fc in treatment of severe COVID-19. CD24 Siglec signaling is important for the immunity and cancer biology. Many of the work pioneered by the OncoImmune co-founders. The most important part is for the inflammation control. CD24 Siglec interaction will activate the SHIP1 kinase and provide the negative signaling to NF-κB activation. CD24 molecule can bind to the multiple danger-associated molecular patterns. CD24 Siglec also showing to be important for the T-cell activation for the phagocytosis as a don't eat me signal for the cancer cells. We recently also have the evidence to show that the CD24 and the CD33 interactions is important for the leukemia relapse control. CD24Fc is an important immunomodulator of host defense in damp response. CD24 Siglec-10 interaction is a novel innate immune checkpoint. There are 2 modes of action. One, CD24 directly binds to the DAMP molecule to reduce the toll-like receptor ligand to reduce inflammation. Number 2, CD24 combined Siglec, then regulate the host response to DAMP. It gives the negative signal to NF-κB activation. It reduces the production of the inflammatory cytokines. The drug product is CD24Fc. This is a fusion protein consists of the human CD24 extracellular domain and a human IgG Fc fragment. The drug is very stable. The stability test showing it can be stable in 6 years in -20 degrees. The drug is given by IV infusion. The half-life of the CD24Fc in human is 14 days. Here's the pipeline of the CD24Fc. We have moved on to the GvHD prevention in phase 3. Now we started the COVID-19 treatment as a phase 3 clinical trial. There's other clinical trials was either ongoing or we are starting now. Now we turn our attention to COVID-19. COVID-19 is a new disease. It took us by surprise. However, there's a tremendous research effort coming through and hundreds of papers already published. We believe there's a difference between the mild COVID-19 disease and the severe COVID-19. In the severe COVID-19 disease, there's 3 important factors: lung inflammation, lymphopenia, and the cytokine production. So the lung damage often peaks even after viral clearance. And the lymphopenia is associated with the severe COVID-19. And the cytokine release syndrome also contributes multiple organ failures. Here we present some preclinical data on CD24Fc that can protect lung from the tissue damage. The first evidence is coming from genetic studies. This is a sepsis model in mice. 70% of the wild-type mice can survive this sepsis attack. However, almost 100% deaths will occur if the mice was born without CD24 molecule or without Cyclad-G molecules. When we look at the mice inside the blood, the bacterial load is very similar. However, the cytokine level is dramatically different. The CD24 knockout mice and the Cyclad-G knockout mice has a huge amount of the interleukin-6, MCP1, and the TNF-alpha. Those are also the cytokines that have been relatively high in COVID-19 patients. The death is caused by the acute respiratory failure, the heart failure, and also acute kidney injury and the kidney failure. This is very similar to the septic shock that at the end stage of the COVID patients. The study showing that the CD24 and the Cyclad-G is important to protect mice from sepsis and septic shock. Without CD24 or without Cyclad-G, the mice just succumb to the sepsis attack. Next is to show the protective effect of CD24Fc in viral pneumonia. This is a model that we infect the monkey with the immunodeficiency virus. When the monkey shows the symptoms of the disease, we randomly separate them into two groups. One will give the CD24Fc, the other will give normal saline as a placebo. When we finally sacrifice the monkey, 5 out of 6 monkeys show the severe lung pathology. We can see from the slide here, from the left side, the lung tissue have the very sick, a lot of the cell crowded there. So there's no way that the oxygen can be exchanged through the lung and the alveolar space. And on the right side is a CD24Fc treated 6 monkey. Only 2 monkeys were sick and have lung pathology, showing this accumulation of a lot of these inflammatory cells. And 4 out of 6 monkeys show relatively normal histology of the lung. Here we show 2 slides that actually coming from 2 monkeys in placebo group. They die very early. From the pathology, we can actually see certain features that represented this acute respiratory stress syndrome, ARDS. ARDS have been shown to be the primary cause of death in COVID-19 patients. Here we give another example to show CD24Fc reduced immunotherapy-related pneumonitis. Cancer immunotherapy has been very successful to control the cancer growth. However, the cancer immunotherapy itself also gives a lot of side effects to the patients. We use a mouse model that can reproduce all the immunotherapy-related adverse events in the mice. When the mice treated with anti-CTLA-4 antibody ipilimumab plus an anti-PD-1 antibody, when we look at the lung, there's a lot of lymphocyte aggregate, and the mice was quite sick and lost weight. But then if we give the ipilimumab anti-PD-1 antibody together with CD24Fc, we see a very minimal disease. Immunotherapy can also cause the myocarditis, the inflammation in the heart muscle. Here is the mice are treated with immunotherapy antibodies. We can see on the bottom, the heart have a lot of lymphocytes get into the heart muscle and get into the atriums. However, when the mice was treated with the CD24Fc at the same time, the heart is clean. There's no lymphocyte infiltrate in the heart. So the CD24Fc can reduce the immunotherapy-induced myocarditis. So next, we are going to talk about another important feature in COVID-19 disease. This is lymphopenia. That means the lymphocyte count is very, very low in the severe COVID-19 patient. And then CD24Fc can actually protect T cell from death. This is a paper just published recently. They are showing 522 COVID-19 patients compared with the 40 healthy controls. These are all the people coming from Wuhan, China. So the study is carried out by the hospital in Wuhan. So they compare the healthy people and the COVID-19, but then they are not get into ICU, and also compare with the ICU patient. From here, that the patient with the COVID-19, whether they get into ICU or not, they have dramatic decrease in the total T cells, CD4 T cell and CD8 T cells. And the people was in the ICU actually have a lot more reduction of the T cell number. And this is the experiments we have done in another mice model. And this is a humanized mouse model to study the HIV infection. So HIV can actually directly infect the CD4 lymphocyte. So HIV can cause a lot of reduction on the T cells. So in this case, we infect the mice and then treat it with CD24Fc. So in this case, on the panel C and D, we can see actually the CD24Fc treatment can actually protect the T cell from the death. And when we look at the T cell exhaustion marker, we can also see that the CD24Fc can protect against the T cell exhaustion in the humanized mouse model. Next, we are talking about the third feature, that is the increase of the cytokine in the COVID-19 patients. We want to show the evidence that the CD24Fc can actually also reduce the production of multiple inflammatory cytokines. Cytokine increase is an important feature in severe COVID-19 patients. Right now, there's multiple clinical trials in different stages using the cytokine receptor antibodies or the antibody directly against the cytokines. They try to see the effect to treat the COVID-19 patients. Here we show the two figures that coming from two papers studied the Chinese Wuhan patients. One is the time course of the cytokine production. The other is in summary of the cytokines. Compare the severe COVID and the moderate COVID patients. What we can see is that in the severe COVID patients, a lot of cytokine was increased. So we come back to our humanized mice with HIV infection. So in this case, we also treated the CD24Fc. So the black bar is the mice with the CD24Fc treatment. We can see the black bar showing the cytokines much lower than the white bar. The white bar is the placebo control. This here will show that in the animal models that the CD24Fc can reduce the production of multiple inflammatory cytokines. CD24Fc already in the human clinical trial for the other indication. So we have these monkey tox studies this is what's carried out in the Charles Rivers lab. We can inject the monkey as high as 125 mg per kg and didn't show much toxicities. And in the phase 1, we used the CD24Fc in the healthy volunteers. We can dose the patient to up to 240 mg in the single dose, and we know that the half-life of the CD24Fc can be 2 weeks. Here's the result coming from the phase 1 studies. We show that the CD24Fc reduced the expression of multiple inflammatory cytokines and chemokines 3 days after the dosing. All these little red dots are inflammatory genes. They have expression level reduced. And we actually did 8 different cytokine, chemokine, RT-PCR, doing them one by one for each samples. Here we all show that no matter which genes, TNF-alpha, interleukin-6, the chemokine CCL2, L3, they all showing the relative decrease from each subject. And when we look at the 42 different cytokines, chemokines, all the transcription factors that can induce inflammatory cytokines, we see this post-treatment, they're all showing the blue colors, meaning the expression levels are reduced. This is a result from the phase 2 studies. This is really show the efficacy of the CD24Fc. So the disease is acute graft versus host disease. When the leukemia patients undergo the bone marrow transplantations, the most severe complication is the acute GVHD. We use the CD24Fc to prevent the acute GVHD. So the results showing that the CD24Fc can significantly improve the 180-day GVHD-free survival and improve the 1-year relapse-free survival and 1-year overall survival. This is really show the efficacy of the CD24Fc. They truly have the treatment effect. When we say CD24Fc is an immunomodulator, we always got a question about the infection. Will patient using the CD24Fc have more infection? So here is the safety data from the phase 2A and the phase 2 expansion. There are 38 patients who have been using different doses of the CD24Fc treatment, and there's actually 6 patients was in placebo group. When we look at the data, so 2 out of 6 in placebo group actually have a grade 2 severe infection, and the 3 out of 38 in CD24 treatment group have a severe infection. So this is clearly to show that the CD24Fc does not affect the infection rate in the hematopoietic stem cell transplantation patient. Based on the molecular mechanism of the CD24 cyclet signaling pathway, the strong preclinical data, and the human experience, we proposed the phase 3 clinical trial using CD24Fc for the treatment of the COVID-19. FDA gave the approval of the IND on April 8, 2020. The Western IRB approved the study on April 9th, and we opened the site in University of Maryland Medical Center on April 20th. The multi-site principal investigator is Dr. Zheng, who is the Director of Clinical Care and Research in the Institute of Human Virology. He's also the Chief of Division of Infectious Disease, Department of Medicine in the University of Maryland Medical Center in Baltimore. Our plan is to open 10 clinical sites for the beginning of the clinical trial. The study design is showing here. We're going to enroll 230 patients. they have to be the age over 18 years. They have the severe COVID-19. They have to be hospitalized with the oxygen support. These patients will be one-to-one randomized into CD24 treatment or the placebo treatment. All patients should have the standard of care. CD24Fc 480 mg will give the patient as an IV infusion on day 1, and that's it. That's the treatment. So we are going to follow the patient for 28 days. The endpoint is the time to improvement. So since this is a novel mechanism, so it should be complementary to all the known experimental or the recently approved antiviral treatments. And even for the cytokine monoclonal antibody, we think we are working on the different target. These drugs should be complementary to each. So the primary objective of this phase 3 SAC-COVID clinical trial is to evaluate the safety and efficacy of adding CD24Fc to COVID-19 best available treatment. We're going to compare this two arm, CD24Fc treatment arm or the placebo arm. Which one will get COVID-19 disease status improved? So the primary endpoint is the time to improvement in clinical status from NIAID scale 3 or 4 to scale 5 or higher. So the major secondary endpoint, one is overall mortality rate on day 28. The second is the proportion of patients who died or had respiratory failure defined as the need for mechanical ventilation, ECMO, non-invasive ventilation, or the high flow oxygen device at day 28. This is a slide to show you the inclusion criteria, exclusion criteria, and the NIAID 8-point scale for the COVID-19. The most important inclusion criteria is really this NIAID scale 3 and 4. The patient needs to be hospitalized on non-invasive ventilation or high flow oxygen device, or hospitalized requiring supplemental oxygen. The other inclusion is have to be adult patient, not pregnant, not breastfeeding, and have a confirmed SARS coronavirus 2 infection. The exclusion, mostly the patient should have a normal liver function or the renal function. This phase 3 clinical trial will enroll 230 patients or 115 per arm. We estimate the enrollment should be within 5 months. The patient will be followed for 28 days. We plan to have 2 interim analyses. The first interim analysis will be at 70 subjects. A futility study with a requirement for positive therapeutic activity of CD24Fc is required for the study to continue. The second interim analysis is an efficacy analysis. We should do the second interim analysis at the time when required number of events is at 70%. The sample size re-estimation will be conducted on these 2 interim analyses. So in summary, we think the CD24Fc could be an important treatment regimen in COVID-19 treatment. The CD24Fc targets multiple steps in COVID-19 pathogenesis. 1, it inhibits expression of multiple inflammatory cytokines. 2, it reduces the expression of the T lymphocyte exhaustion markers. 3, it prevents lymphopenia by inhibiting the interferon gamma production. And this is important for maintain the T cell activity and prevent the T cell death during the viral infection. There are 5 important points to why we choose CD24Fc. it has a CMC process and partnership well established. Number 2 is target 3 key steps of the COVID-19 pathogenesis. Number 3, it has an excellent safety profile in phase 1 and phase 2 studies. Number 4, it has proven efficacy in acute GvHD prevention. Number 5, we have FDA approval for the IND application, and the phase 3 clinical trial already started in several clinical sites. Thank you very much. Welcome to your questions. Sorry, before I open for questions, I should make the acknowledgement. Many data presented here are carried out by the lab members in our academic labs in University of Maryland, Baltimore Institute of Human Virology. The humanized mice HIV infection was carried out by the Dr. Lee San-Soo lab in University of North Carolina at Chapel Hill. The monkey study for the viral pneumonia is carried out by the Kunming Institute of Zoology. The phase 2 clinical trial have been carried out by the University of Michigan, OSU, Carmano, and Indiana University. And a lot of prior members and current members in Dr. Yang Liu and Dr. Pan Zheng's academic laboratory also contribute to the CD24 study.